So this is a case study for my advanced pharmacology course. It's a case of end-stage renal disease and mitral valve stenosis. So we have a 48-year-old male with a previous medical history of antiphospholipid syndrome, DVT, and polycystic kidney disease, who is status post-renal transplant, went through rejection, which led to renal failure, and now with dialysis-dependent ESRD. He initially presented with progressive fatigue, dyspnea, leg swelling, and was found to have severe mitral valve stenosis. So his hospital course includes a mitral valve replacement and tricuspid repair, a subdural hemorrhage, for which he went to the OR for a left cranie, and he also had resistant hypertension throughout his hospitalization and some anemia. So discharge goals include a consult to the transplant team for a possible second renal transplant and to set up dialysis near his new home in Salt Lake. So his home medication list is quite lengthy. He takes Tylenol, amlodipine, aspirin, calcium acetate, carvedilol, cilostazol, clonidine, darbepoetin alpha, doxazosin, doxorcalciferol, etacalcetide, nifedipine, omeprazole, prednisone, sildenafil, varenicline, and warfarin. And here is hospital medications. Many of these are the same, but I'm going to go and read them off anyways. Once again, we have Tylenol, amlodipine, atorvastatin, carvedilol, clonidine, darbepoetin, alpha, hydralazine, labetalol, lisinopril, melatonin, naloxegol, omeprazole, ondansetron, oxycodone, polyethylene glycol, prednisone, Senosides docusate, Lokelma, and warfarin. So this table has a list of his home meds and hospital meds that are similar or the same. So he takes Tylenol, both inpatient and outpatient. He takes amlodipine also in both scenarios, same dose as well. Coreg, he takes an increased dose in the hospital. The clonidine, he also has an increased dose inpatient. For the Aranesp, he is on a reduced dose, it looks like, at 40 micrograms instead of 125. For his nifedipine, there's a similar medication, calcium channel blocker called clonidine that he also takes. He takes omeprazole both at home and in the hospital. He takes prednisone, same dose as well, and the warfarin is looks like a reduced dose, 7 milligrams. Okay, the next few slides, we're going to discuss medication interactions, and there are quite a few because he's on several drugs that are in the same class. But we'll start at the top. He takes carvedilol and labetalol. That interacts with clonidine, causing enhanced effect of carvedilol and sinus node dysfunction, and that can also cause rebound hypertension when clonidine is withdrawn abruptly. For the cilostazol and the omeprazole, enhanced serum concentration of both drugs can occur if taken concurrently. For doxazosin and sildenafil, the sildenafil enhances the hypotensive effect of doxazosin. And then we have oxycodone and clonidine. So the clonidine can actually enhance the CNS depressant effect of oxycodone. And when you take warfarin with Lokelma, the Lokelma may increase the warfarin levels, so you need to be aware of that for bleeding risk. Same thing with aspirin. Aspirin enhances the anticoagulant effect of warfarin. For the amlodipine, it interacts with sildenafil, and the sildenafil enhances the hypotensive effect of amlodipine. And melatonin, when taken with amlodipine, may diminish the antihypertensive effect of amlodipine, so it may not lower the blood pressure as well. For aspirin and cilostazol, and these are class C, by the way. The previous ones are class D, starting with the worst reactions to the least. We're only going to discuss D and C for the purpose of this PowerPoint. There's just so many interactions with these drugs. But for the aspirin and cilostazol, this can enhance the antiplatelet effect of both drugs. So again, increased risk of bleeding. For the carvedilol, labetalol, those two drugs combined with nifedipine. The nifedipine can increase the hypotensive effects of the beta blockers. The same drugs, carvedilol and labetalol, when taken with sildenafil, the sildenafil also increases the hypotensive effect of the beta blockers. Slide number 2, I apologize, there's so many, but we have carvedilol and labetalol. You got two beta blockers taken together, so this can cause bradycardia. We have clonidine and sildenafil. The sildenafil can enhance the hypotensive effect of the clonidine. Also, when taking doxazosin with carvedilol or labetalol, the beta blockers may enhance the orthostatic hypotension effect of doxazosin. So for the doxorcalciferol, we have calcium acetate taken with that. So this combination may enhance the adverse effects of the doxorcalciferol. For hydralazine and sildenafil, again, increased hypotension. For lisinopril and aspirin, and this can actually enhance the nephrotoxic effects of the lisinopril. For the lisinopril and the sildenafil combination, Again, a recurring theme here, enhanced hypotension with these two drugs. So for the naloxegol and the carvedilol may enhance the serum concentration of naloxegol. For nifedipine and sildenafil, sildenafil enhances hypotensive effect of nifedipine. And when nifedipine is taken with melatonin, the melatonin may diminish the antihypertensive effect of nifedipine. And for the nifedipine taken with calcium acetate, the calcium acetate may actually diminish the therapeutic effect of nifedipine. And last slide here of interactions. I'm sorry, there's so many. The nifedipine interacts with doxazosin, increase hypotension. Again, with prednisone and aspirin, aspirin may actually enhance the adverse effects of prednisone, and this includes like GI bleeds, ulcers. And with warfarin taken with cilostazol, the cilostazol may enhance the anticoagulant effect of warfarin. And warfarin taken with Tylenol, again, same thing. Warfarin taken with omeprazole increases the serum concentration of warfarin when those two drugs are taken together. And then lastly, we have warfarin and prednisone. The prednisone, again, increases the anticoagulant effect of warfarin. Okay, so now let's look at his home medications that were discontinued when he was hospitalized. We'll start with aspirin. The reasons are pretty obvious. It's increased risk of bleeding, particularly with warfarin. And the next drug will be calcium acetate or Foslo. So his FOS levels were actually pretty stable during his hospitalization, so there was no need to keep the phosphate binders on board. He was getting dialysis nearly daily, and we were closely monitoring that. Next, we have cilostazol. This drug can cause an increased risk of bleeding when taken with warfarin. Next drug will be doxazosin. This was DC'd also. It's typically used for BPH, but the patient is now anuric, so there's really not a need for this drug for him. Next drug would be doxorcalciferol. So this is an injection that reduces PTH to control calcium levels. This was held because his calcium was also within normal limits and being monitored closely. And the same scenario for edocalcetide with the calcium levels. And for the nifedipine, this was DC'd because the patient was on multiple antihypertensives already. And next we have sildenafil. This was DC'd because there's an increased risk of orthostatic hypotension, and the patient was being anticoagulated and at risk of bleeding, particularly if he were to fall. For the last drug here, Chantix, this one can cause nausea, sleep disturbances, and increased delirium, so that's why it was DC'd. Okay, so this is a table of medications that were not on this home list that were added upon hospitalization. First drug here, hydralazine. This one was added because his uncontrolled hypertension. Now, the risk involved with this one is, of course, hypotension when combined with all the other hypertensives or antihypertensives he was taking. Next, we have labetalol, also for hypertension, and this one carries a risk of bradycardia when combined with beta blockers. Next, we have lisinopril. This is also an antihypertensive and poses a risk of hypotension when taken with all the others he's taken. Okay, and this next table is a list of medications that were added during his hospitalization. First one is hydralazine for his hypertension. The risks with this, of course, are hypotension when combined with all the other antihypertensives he was taking. Labetalol, this was also for his persistent hypertension. This carries a risk of bradycardia when taken with other beta blockers. The lisinopril was added as an additional antihypertensive, also a risk of hypotension with all the others he's taking. Melatonin was added as a sleep aid in the setting of hospitalization. This drug carries a little risk, but it could diminish the effect of amlodipine. And then we had naloxegol. This is given to prevent opioid-induced constipation. So the risk of this drug is it could cause GI upset, and the carvedilol could increase the serum level of naloxegol. For ondansetron, this is for nausea control. There's not really much risk to this drug other than a prolonged QTC. Oxycodone would be the next drug. This is for his post-op pain, and of course this carries a risk of constipation and oversedation. Next drug will be Docusate. This is a stool softener, pretty standard drug given in inpatient settings, and there's really no risk that I know of for Docusate. For Lokelma, this is used to lower serum potassium. Risk of taking this drug are constipation, hypokalemia, and an increased warfarin serum level. Okay, let's talk about the management of hypertension. So guidelines for the treatment of hypertension include being on multiple medications if needed. So if a single agent doesn't control blood pressure adequately, several may be used in conjunction. And for an example here, a patient may be on a diuretic, an ACE or an ARB, and a calcium channel blocker. And if those three classes don't work, a fourth drug can be added, such as another beta blocker or clonidine. So this particular patient was on 5 antihypertension agents at home. And here they are here. He's got 3 calcium channel blockers, a beta blocker, and an alpha blocker. So this guy's hypertension is very resistant to medication. So while he was inpatient, we had systolic BPs of greater than 180, despite all those antihypertensives. So we had to add in some PRN medications, labetalol and hydralazine, to help control that. And he was receiving those frequently. And some other parenteral drugs that could be used are nitroprusside, hydralazine, labetalol, and fendoplam. Okay, let's talk about recommendations for orders and prescriptions. I would recommend that we continue the lisinopril after discharge to help with his blood pressure control. Next, let's wean the clonidine. This is his 4th antihypertensive agent, and we want to reduce this slowly in increments of 0.1 milligrams every 3 to 7 days. And we'll want to monitor his blood pressure and heart rate closely. Next, I'd recommend holding the FOS low because his FOS has been normal throughout his hospitalization, and we can obtain FOS levels on his dialysis days and restart those outpatient as needed. Next, I'd like to hold the Aranesp for a hemoglobin greater than 11 because this carries a risk of MI, stroke, and VTE. Lastly, I would recommend outpatient cardiac rehab due to his deconditioning and recent mitral valve and tricuspid valve repair. He's very deconditioned and weak from a prolonged hospital stay, so I'd definitely recommend that. And here we have recommendations for patient and family and nursing staff. For the patient and family, I would recommend educating them about the medication risks that they carry, the side effects, and what they're taken for. To encourage them to ask questions and have the family participate in making sure he's taking his medications appropriately, and to encourage him and to help him keep track of his blood pressure is going to be very important as well. Next, I would encourage him to use hospital resources to help him cope with this chronic illness and his recent surgery. I would encourage the family to help coordinate dialysis appointments so he doesn't miss any, and also just to check on the patient's mental well-being, as this can be a stressful time. For nursing staff, I would encourage nurses to educate the patient and the family about this disease process, end-stage renal disease, and the post-op cardiac surgery he had. And I would encourage the nursing staff to work with the providers to adjust, modify, or discontinue medications based on the patient's condition. I would encourage nursing staff to give medications according to order parameters. For example, if the patient has hydralazine and labetalol, I would probably try the hydralazine first, and then if that doesn't work, we could go to the labetalol. I would encourage nursing staff to minimize opioids for pain control, to try to go with non-pharmacological pain management strategies so he doesn't become dependent on opioids. And lastly, I'd recommend that they monitor for constipation and adhere to any fall precautions. And I appreciate you watching. Thank you.